Open, outspoken, it's Ophthalmology Off the Grid, an honest look at controversial topics in the field. I'm Blake Williamson. Welcome to another episode of Ophthalmology Off the Grid. In this episode, my co-host, Dr. Tal Raviv, and I chat with Allon Barsam, the director and founding partner of OCL Vision, a bespoke private ophthalmic surgery practice in London, England. In this episode, he tells us about the logistics of running a private practice within the UK's National Health Service, how he makes OCL Vision stand out among local competitors, and some of his favorite IOLs available in Europe and the United Kingdom. Coming up on Off the Grid.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome to another episode of Ophthalmology Off the Grid. I'm your host, Blake Williamson, here with my amazing co-host, Dr. Tal Raviv in New York City. Tal, how you doing, man?
All is good in New York. Thanks. Jets won. That was a big victory.
Yes. Over the Bengals and my Joe Burrow from LSU. I couldn't believe that, man. Is there some excitement up in the Jets Nation right now?
Maybe a little bit, but very guarded. Very guarded. It's they were making references to Testaverde. I was like, last time it was. Anyway, we're dating this podcast now, and my fandom. So let's move on to
yeah. So you had a great idea for today's session and today's podcast, and I think it's going to resonate with a lot of people to kind of give us, especially here in the States, give us sort of a unique perspective of what it's like to start a practice similar to you and mine overseas. So why don't you introduce our guest, and we'll go from there.
Well, thanks, Blake. And it's great to have Allon Barsam here. Allon is the director and founding partner of OCL Vision, which is a bespoke private ophthalmic surgery practice in London. He's a cataract, cornea, refractive surgeon who is frequently seen, in publications and presentations internationally, et cetera. He and I met years ago at an international meeting somewhere and have hung out over the years. He did his fellowship in the United States after training and residency in UK, went back and started something that is very few people do. He started a successful solo practice in the UK and then built it into what is now just a multi-site practice called OCL Vision. So I am very, very honored, happy to have Allon here. Allon, how you doing?
I'm good. Thanks very much for having me.
Thanks for coming. The reason, one of the things that will break this whole conversation is I had a patient, 5 months ago that brought her mother in who was here from Ireland and she needed to get surgery. I said, why aren't you having it done in Ireland? And she said, there's a 1.5 year wait. And I thought, that can't be true. And it is true. So maybe I want to start off by what the landscape is like there in the UK, but tell me, why is there a 1.5 year delay in cataract surgery? We know, give us a background a little bit.
Yeah, well, I think the first thing is that Ireland is a bit separate from the rest of the UK. Obviously, it depends on which part of Ireland that they're from.
Or what is it in the UK? I mean, I'm sure, what is it where you guys are?
Well, I mean, it varies depending on the region, but it's certainly a lot longer than it ever was before. In some regions, it can be as low as 2 to 3 months, but in some regions it's, 9 months or more. We actually tried as a practice to try and get some, real data on this by contacting the National Health Service trusts in various regions. And it's quite difficult to get a real handle on exactly how long the wait is, because it really depends on how they categorize it. Like, do they categorize it from when a patient first gets referred? Do they categorize it from when the patient gets seen and then, gets listed for surgery until they actually have the operation? And it's difficult to really know for sure, but there's no doubt that the waiting lists have become much longer than they were before. And they were quite long before, actually, in the UK compared to somewhere like the US.
And why is it? I mean, if you're a surgeon working for the NHS, is there no incentive to do more surgery? That's the question. Usually it comes down to that. Are they blocked for time?
Yeah, I mean, it's not just about incentive. It's also about resources. And yes, I mean, you could argue that the whole organization is not incentivized in terms of at least financially incentivized to be more efficient, because it's not an economy like the kind of real world economy, if you like. Like there's a kind of limited amount of money that the government will put forward for the services, and then people make decisions on how that money should be spent. is one particular answer. But also, to be honest, even if you assumed that everyone working in the NHS was as motivated as possible to be as efficient and as hardworking as humanly possible, which is certainly the case in some places, and then it's just limited by resources. So it's limited by the number of nurses that you have there, the number of surgeons that you have there, the number of operating theatres that you have there. But there's no doubt, having worked in the National Health Service in the UK, having worked in the US private practice, and then obviously being involved now in a merger with my now partners in a private practice organisation in the UK, that there are a variety of different models of care, and it does have an impact on things like waiting times, on things like the work ethic, how people work and how efficient they are, and obviously in terms of like the resources that are available. That's a huge thing.
It sounds like as a result, a whole crop of private practices have come up, and we'd love you to speak about that anyway.
In the UK? Yeah,
it looks like there's a whole bunch of ways to do cataract surgery outside the NHS, different types of practice settings, and that's where you guys have sort of found the niche.
Yeah, that's what I'm curious about too. Is it similar to where it is in the US, where I'm just curious, like what roughly percentage of ophthalmologists are working inside of a hospital setting versus sort of a not necessarily a cash pay private practice, but can you still be in the NHS and have a separate sort of freestanding clinic, kind of like we have here in the States, or must you be inside like a big hospital?
Yeah, so it certainly used to be the case that it was really either, all kind of an NHS hospital, like a big hospital, that like similar to how I guess the VC hospitals would be in the US, or there would be private practices, which might be bespoke ophthalmic private practices, which are actually surprisingly rare in the UK, but more commonly are just private hospitals that do all of the specialties, of which ophthalmology is often one. But what's happened over the last few years, and it had happened previously about maybe 10 years ago, and it kind of went away, was the independent sector, which are for-profit organizations contracting out their care to the government. So it has become a little bit more, I guess, confusing, if you like. You can't just categorize it as kind of National Health Service hospitals and, private practice providers. And in fact, according to their own claims, and I don't know whether this has been substantiated or not, last year, the number one provider of cataract surgery in the UK was actually a private provider called Spar Medica, which is basically a private organization which contracts out NHS care. It was recently bought by Nordic Capital in a massive private equity deal. And they are able to do cataract surgery on NHS patients for profit, and are trying to do it with as much volume and efficiency as possible, if you like. It obviously creates a lot of problems because they tend to only operate on the most straightforward cases. They tend to not do any training or teaching. And so it leaves the National Health Service with a even greater amount of complex, difficult cases to do. And that makes it then less able to teach and train, because if you only have, dense rocks, only eye patients, highly mobile pseudoexfoliation, you can't really teach anyone to start doing cataract surgery if that's kind of what you're left with, if you like. And in fact, I published a paper back in about 2002 or 2003, which was the last time that the independent sector was really big in the UK, looking at how it affected the case mix. Because when it came into one region, we looked at the case mix within the National Health Service before and then after, and we found it made things significantly more complex. And I think that's the way it's going. So that creates problems. But from what we do in our private practice, we don't do any NHS care within the private practice. All of us, as it happens, still do NHS work separately. So we kind of give a certain amount of time to the NHS outside of the commitment we have to our private practice. But what we do in our private practice is really, I guess you would call it more kind of premium or high end. It doesn't really address we're not really looking to do, half of all cataracts in the UK if we were to, let's say, scale nationally. It's really patients that want to have premium lenses, that want to have a specialist looking after you, that want to be able to choose the consultant who's looking after them, that want to avoid waiting lists, that want to have some flexibility over when they have their surgery. The kind of stuff I think that you'd be very familiar with in the US. It's not that different. The reimbursement structure and doing it within a environment where the National Health Service is still doing the majority of cataract cases makes it a little bit different in terms of the volume. But in terms of the kind of how the patients are motivated to seek care, how they access us, and then the kind of care that we try and provide for them, I don't think that you'd find it that dissimilar.
It looks like since there's waiting lists and NHS has trouble keeping up with the volume, there's different solutions have cropped up, and it seems like there's private hospitals, as you mentioned, there's private corporations that do cataract surgery, and then there's you're doing something which is the high touch model, as you mentioned. What led you to choose this? And what's interesting about the high touch model is, people are coming there and taking out their credit card, I assume, mostly, or is there a secondary insurance market? Tell us a little bit about that.
Yeah, I mean, there is a significant insured market. So I think it's estimated that about 10% of the UK has private medical insurance. So because people are aware, either because people are aware that there may be limitations with NHS care in terms of waiting times, in terms of choice of surgeon and consultant, choice of location, or even the technology that they can have available. Like, for example, if you wanted a multifocal lens implant, there is no co-payment allowed in the National Health Service. You can't go to the National Health Service and say, look, I don't mind who the doctor is. I don't mind waiting 6 months. I just want to make sure I have this implant. You can't add on and pay additional for an implant within the NHS. It's like either totally free or you go somewhere else. So people will look elsewhere for that reason. And in terms of the high end or high touch, it just kind of came about. Like it's if you're doing private practice in the UK, then that's kind of what it is by default. Otherwise, you're not really providing patients with an alternative to what happens in the NHS. So, in my opinion, the more there are many excellent things about the NHS. The NHS is very good at kind of maintaining a safe minimum standard. It's very good at what we call clinical governance, which is things like auditing of results and ensuring that everything is done safely. It tries to standardize certain things, which can be helpful. And so there are things that are of benefit in terms of what we've learned within our NHS, careers. But I think that what we really try and do in our practice is almost like a discriminator from the NHS. And even on our website, we have things that show the difference between, NHS cataract care and cataract care
or something like that
with us. Some of which we've mentioned, choice of lens, choice of surgeon, wait time, et cetera, et cetera. And the seniority of the surgeon is a big deal as well, actually, because, in the US, whether you're working in the VC hospitals or whether you're working in private practice or whether you're working in a university hospital, it's normally an attending, i.e. someone that is fully qualified that is delivering care. The residents do relatively few cases. You might do 200-300 cataract cases over 3 years, but there are thousands and thousands and thousands of cases happening all the time. In the UK, residency training is 7 or 8 years, and just the statistics of that mean that statistically in many institutions, not all of them, but in many institutions, it's statistically unlikely that a consultant will do your operation, especially if it's a place that's there for training. So it's another factor, so with us, obviously it's a consultant that does the surgery. That's important to some patients. They want to be able to choose who the surgeon is. And then the technology, as you guys know, the technology has just become massive. And in fact, one of the reasons that I personally wanted to move out of solo practice and form a partnership with other guys that had a similar ethos to myself, is that I just felt that the technological requirements and options in all elements of ophthalmic care, by the way, not just cataract surgery, but everything, were only going to become greater. There was only going to be more expensive lasers, more that you could offer, more technology required, more resources needed, and doing that in numbers in a meaningful way. Really, it's a huge discriminator. You just have to walk into the practice and it would be obvious to patients what the difference is.
Yeah. I'm thinking, for us here in the States, like, we can kind of have our cake and eat it too, in terms of like, we can charge Medicare and Medicaid, but for those patients, if they want to pay extra, then we can have a boutique practice within our practice. We don't have to go out there and say, you know what, we're opting out of Medicare and all that. I know some practices do, but you guys, it's kind of all or none. You can still have some time at the NHS, like you mentioned, but within your private practice, it sounds like it's kind of all or none. I'm just wondering, what you're doing sounds so much more appealing to me because that's kind of what we're familiar with over here. What percentage of residents that are graduating in the UK, what percentage of them end up doing something similar to what you're doing versus sort of just going to work for the NHS? Is it getting bigger, and how is that changing?
So almost everyone will start off working in the NHS when they finish their training. And that's, I think, because the NHS is so involved in training, because it's just what everyone does. And if you don't do it, I think people will look at it and go, why did you not commit any time to the NHS? It's really like a part of the soul of the British people, if you like. So it would be, I think, frowned upon for someone to kind of come out of training and not commit any time whatsoever to the National Health Service. But obviously there's huge varieties of what people are willing and prepared and committed to do. Some people only work in the National Health Service, never do any private practice. Some people will just spend a couple of years or a few years in the National Health Service, and then go into full private practice. What most people do is they'll work part of the time in one and part of the time in the other, and find a balance that they as individuals are comfortable with. And some of that is determined by the geography that you're in. Like London, for example, there tends to be there's more volume of private practice, if you like, probably more concentration of people that have private medical insurance, and the cost of living is higher. So the kind of the income that you get from the National Health Service is pretty standard. I mean, there are excellence awards. So if you do kind of above and beyond, then you get paid a little bit more, but it doesn't vary hugely whether you're in central London or whether you're in, some outer region of the UK where, the cost of living is much lower, in terms of house prices, schooling, all the other things. So sometimes it's people's own personal motivating factor for what they need or want to earn that influences the decision. And I think the average ophthalmologist in the UK probably does the majority of their time in the NHS and might then do one or two sessions, which would be like one, clinic or one operating list or something like that, maybe every other week an operating list and maybe one clinic a week. So they're really spending a minority of their time working in the private sector. And I think, there are a huge variety of reasons for that. I mean, I think that to be honest, the private practice landscape in the UK, I would say, with all respect, and there's some obviously excellent people out there in excellent institutions, but on the whole, it is relatively immature compared to the US. You guys have had decades to build effective businesses and organizations with large groups of people that support the work that you do, not just doctors, administrators, managers, people in accounting, finance. And I think that if you look at, for example, the private equity, appetite for having a piece of that in the US, if you like, I think is testament to it. They recognize that these are successful, profitable, stable businesses, where there's only more potential for doing more in the future. And in the UK, I think because of the National Health Service, it's kind of, you only have to be better than the National Health Service in order to justify someone coming to you. You don't have to be, providing the best level of care for the country, for Europe, for the world, for example, at the moment. But, it is becoming more competitive and it is progressing rapidly. And I think the problems that the NHS is having with its waiting list, with what's happened in the wake of COVID, have created a lot of opportunity in the private sector. All of us are working much harder now, and we're much busier than we ever were before.
Well, I'd like to focus in a little bit about your practice. I've seen you on social media and you're active. And I know that since people have to use their own money in many cases to have this surgery, you have to compete for that. You have beautiful offices. Tell me a little bit about what is it that you guys are doing to stand out. I know you have some really cool post-op swag bags. You also don't have the insurance company telling you what you can and can't do like we do here. And is it true that you guys do bilateral surgery? Do you do in-office surgery? Tell me a little bit about that.
Yeah, I mean, I think that we aren't regulated by the insurance companies like you might say that you are in the US, but the insurance companies do impose limits on pricing. And there are some limits on how we do things. For example, there's often package pricing where you kind of, especially as a new provider, you have to kind of accept their fees in order to be recognized. And you can choose not to be recognized, or as you would say, opting out, as you might opt out of Medicare or Medicaid. So we could opt out of some of the kind of lower paying, higher volume insurers But we've chosen not to do that. We're not, that's not really our model. We actually want to make, although we are premium and high touch and high end, we believe that it can be made available to most people. And we're kind of passionate about the idea that the kind of private eye care that we provide is the best kind of private eye care available. And we would like to make that available to as many people as possible. Clearly, there will be some people where affordability is a barrier, but actually, even for them, we've looked at ways to try and make it manageable. We look at financing schemes over 2 or 3 years. We've tried to keep our kind of low end procedure, like for example, a cataract operation with a standard monofocal lens and no femtosecond. We've tried to keep that as competitive as possible because we don't want to. It's not because we need to compete with our competitors, because we're almost too busy at the moment. But it's more that we don't want to charge something that we think is unfair to that patient, because we know that whatever we're charging, most people probably could find a way to essentially pay for that if they were motivated to. Maybe they'd have to finance it over 2 years and cut back on other things like holidays or trips abroad. But, people do prioritize health. So we want it to be accessible to as many people as possible. And in terms of like how we get the message out to patients, with you guys, the majority is word of mouth. So all of the other stuff that you're aware of through social media, through branding, through, all that kind of stuff, that's really just for the kind of 10 or 20% maximum of patients that might be shopping around, that might be thinking, do I go here? Do I go there? Most of it, to be honest, is to reinforce what the patients already know, right? So someone said to them, you need to go to OCL Vision and have cataract surgery because those guys are great. All right. Then when they're on social media looking up, cataract surgery with multifocal lenses, when OCL Vision pops up, it kind of reinforces that message. So I think that for people, that many people have a kind of simplistic view on marketing, as though just one thing puts the idea in a patient's head and that's how they make their decision. Like they happen to be reading something in a newspaper, or they just happen to be browsing on Google, or they happen to just be speaking to their friend. There's often multiple things that will influence the decision, especially amongst the most discerning of people. And it's the people that are most discerning who did the most research, who thought about it the most, who sourced information from the widest possible, spheres of influence, are the ones that tend to generate the most word of mouth, because people listen to those people. People that are like happy-go-lucky, easygoing, impulsive, people are like, yeah, what did you really care about who you went to? Do you really worry about it or care about it? The people that really like research it thoroughly, those are the ones that people tend to listen to. So yes, we want to be present in all areas of where people might be looking, but word of mouth is a huge driver. You do a good job for someone, they see really well, they don't need glasses, they're telling their friends about you, and then the other stuff is all extra, to be honest.
Yeah, when I was there, I went and visited. I didn't know you well enough yet, but now that I know you, I'm going to invite myself to your practice. But I went and hung out with Julian at Moorfields, and I went to Dan's practice and kind of saw, his clinic and how it was set up. And gosh, it just couldn't be any more different. With the private practice setting, you guys, you can pick the couch you want. You can pick the color paint you want. You can pick, do you have flowers or do you have sculptures at the front desk? I mean, talk about how fulfilling it is kind of choosing the route that you did. And maybe that's a sign of things to come in the UK. Hopefully it can start to become more like that everywhere, because it just sounds such a better way to live.
Yeah, we're really lucky. I mean, the journey has been a lot of hard work and it's been a lot of heartache. And we've done a lot of hard work before even merging as OCL Vision within our own practices to have that kind of, volume of patients. But there's really no looking back for us. It's very exciting. We're kind of constantly thinking about the new thing, the next thing. And our plan is to kind of, continue to grow. But you'd be very welcome to visit and join us whenever you're in town.
I'm going to visit with Blake also, because that sounds great. And I know Blake has done a lot of visiting other practices, which is so critical for anyone. Just learn so much more by going somewhere and just sharing what they're doing. As we wrap up a little bit, let's just focus a little on technology. We know Europe and the UK are so much ahead of the US as far as approvals. Tell us a little bit about what you're using in your toolbox these days. I know you've had the IC8, but what about sulcus IOLs? I find I always see patients that could use a sulcus multifocal or something. I know they're available. Are you guys using that kind of stuff? what's your favorite multifocal these days? What are you doing over there?
Yeah, so I like the Rayner trifocal. So my favorite multifocal is a trifocal, and there are a few trifocals now, and it's, there's subtle differences between one and the other. But the Rayner trifocal is my preferred trifocal. Rayner also makes sulcus-based lenses, so they make the Sulcaflex, which can be also trifocal. But I don't use a huge amount of sulcus lenses, to be honest. I mean, I tend to use them for refractive surprise if I think that LASIK isn't a good idea, if they've got dry eye or something of that nature, or it's a high hyperopic refractive surprise, then I might use that. But there's a lot of exciting kind of premium monofocals, or you could call them increased range of focus lenses, like the Ray 1 EMV lens, which induces a bit of controlled positive spherical aberration. And it's quite nice transitioning from a kind of standard monofocal practice with some toric lenses and some trifocals to essentially a kind of almost 100% premium lens practice, because there isn't a huge reason not to give someone a little bit more rather than just a standard monofocal. They can have a bit more range of focus without losing anything in quality of vision. So I think that's pretty exciting. And I think in 5 years, that everyone will be having lenses that give them some more depth of focus than a standard lens, unless, with rare exception.
And what about, I have to ask about MIGS, because, MIGS, from what I understand, hasn't really taken off quite as much in the UK, as it has here in the US because of reimbursement and, things like that. Is anyone charging, like in a practice like yours, is anyone charging, cash to do like an eye stent or a MIGS procedure for those patients with glaucoma? Is that a model that's happening?
Yeah, I think it is happening. And I think, I imagine that the insurance companies are asking patients to top up. So I think the uptake is probably because the top up for MIGS is probably not palatable to patients. I also know that the issue with glaucoma is that because it's considered a chronic disease, that often insurance companies will kind of exclude patients when they renew their policy from 1 year to the next. So I think that in glaucoma, it is a bit more problematic. And we have a glaucoma specialist who does all that kind of stuff at OCL Vision. It's not something that I personally do.
Well, thanks so much for taking time to explain your practice and tell us what's going on over there at the UK. Can't wait to see you all in person at the next maybe ACOS meeting or somewhere else. And I look forward to visiting.
Likewise. Thank you so much for having me.
Thank you, Dr. Barsam, for joining us on this episode of Ophthalmology Off the Grid, and thank you to our listeners for tuning in. This has been Ophthalmology Off the Grid. Until next time.